Good morning, everyone. Welcome to this webinar on addressing urinary incontinence in older women in European nursing homes towards dignified, sustainable, and equitable care. My name is Federica Margheri. I'm the Executive Director at the European Health Management Association, and I will be your host for this webinar. Throughout this year, the European Health Management Association has had the pleasure of working with key stakeholders in continence and women's health. Together, we established ALLIAX, the European Alliance for Managing Severe Chronic Urinary Incontinence in Older Women in Nursing Home. And together, we have produced a white paper that we have the pleasure of presenting to you today. I would like to take the occasion of thanking Becton Dickinson, BD, who has generously contributed to the implementation of this project. Now, as many of you certainly know, urinary incontinence is a prevalent but also under-recognized health issue. It affects the aging population and especially it affects older women in nursing homes. It impacts profoundly both the patient dignity, independence, and quality of life. It also imposes high economic cost as well as produce significant waste and environmental burden. To discuss this important topic, I am joined today by an esteemed panel of speakers. I have with us Alexis Strader. She's the Director of Policy and Research at the European Health Management Association. I have Mr. Pascal Storner, Managing Director and Head of Inpatient Care Division at BPA. We have Ms. Panagiotta Tsikala, Policy Officer at the European Specialist Nurses Organization, Professor John Hessaker, member of the International Continence Society, MEP Vytenis Andriukaitis, and Ms. Elena Weber, who is board member of the European Aging Network. And to kickstart the discussion, I would like to hand over to Alexis Strader. As I just mentioned, she is the Director of Policy and Research at the European Health Management Association, and she will be presenting the ALLIAX white paper that we have produced this year. Alexis, I hand over to you.
Thank you very much, Federica, and good morning, everyone. Thank you so much for joining and for taking your time out. Thank you, MEP Andriukaitis, for being here and for giving us your support. We very much appreciate it. I just want to check first that you can see my slides.
Yes, we can.
Great. Okay. Thank you very much. I'm very glad to be here today. I'm just going to share some highlights from our white paper that we developed in collaboration with our Alliance members. And please do go to the EMA website to download the full white paper. And I encourage you to take some time later on to go through in detail the contents of this paper. I also want to recognize my colleague, Lisa Becker, who took the lead on this project and did the majority of the work on this paper, and we thank her very much for her contributions. So with that, I'm going to kick it off just to give a quick impact snapshot, because I think most of you will probably agree that there's a big taboo around the topic of urinary incontinence. Most people are uncomfortable with discussing it. So a lot of people, just even public health professionals, aren't aware of just the impact that it has on older individuals, especially older women, and especially in nursing homes. So that's what we want to shed a light on. That's what we're trying to raise awareness on. So I want to give you some key facts and figures first, and then I'm going to go into a little bit more detail on the economic burden, the environmental impact, and the clinical burden. But overall, just some figures that I think you might find surprising, because first of all, the prevalence is very high. 50 to 70% of people living in care homes suffer from urinary incontinence, both men and women. There's also a huge economic burden, 70 billion euros across Europe in terms of cost of UI management. And we talk about this because health systems we know are already under strain. And so this economic burden is especially worrisome. It also creates a lot of waste. UI management often is the primary way of managing it is through adult absorbent hygiene products. And these end up in municipal waste. And in fact, about 5% on average across European countries. This is more than infant absorbent hygiene products. There's also, of course, the psychological distress and the social isolation that comes with UI. I talked about the taboo. For a lot of folks suffering from this, they don't want to talk about it and they're embarrassed by it. So there's social isolation, but there's also an increased risk of falls and bone fractures because of it. And we know that women are disproportionately affected. 30 to 40% of older women report UI, and they bear a significant economic burden, especially compared to men. And we know especially that, as the aging population in Europe increases, this burden will only continue to increase. So as I said, there is a significant economic burden, and it will rise by 25% by 2030. It's because of the high cost of the absorbent hygiene products, but it's also due to the cost of avoidable hospitalizations and complications, and also the time-intensive management for the health and care workforce. This is because they need to change bed sheets, they need to change the absorbent hygiene products, the catheters, change clothes, bathe patients. So a lot of their time and effort is devoted to UI management. The economic burden can't be ignored either, or excuse me, the environmental impact can't be ignored either. As I mentioned earlier, absorbent hygiene products end up in municipal waste. It's a pretty big percentage. They're also use fossil fuel to create these products. And so this, has the environmental impact. Disposal, they can't be recycled. So it varies by country, but, this is the fact that there's no easy way to dispose of them complicates matters. And so there's a big opportunity for transitioning to sustainable UI management. Of course, when talking with this topic, we can't ignore the clinical burden, both for patients and the health and care workforce. I already mentioned some of the issues that impact patients, but there's also with UI increased rates of urinary tract infections, catheter-associated UTIs, incontinence-associated dermatitis, pressure ulcers. I talked about the risk of falls and dehydration. This is because patients in nursing homes are getting up to go to the bathroom at night and falling, or because they're trying to manage their UI, they will not drink liquids, and so then they suffer from dehydration. So overall, there's a significant impact on their quality of life and their mental health. And in fact, incontinent residents in nursing homes have reported significantly worse quality of life compared to continent residents. For the health and care workforce, the time-intensive management, which I already talked about, having to change absorbent hygiene product, and this also puts a strain on them physically, moving patients, having to turn them to change their clothes, and doing this over and over again throughout the day. We know that the primary cause of low back pain, for example, for nurses, nursing home care workers, and family caregivers is because they are cleaning and handling patients. And so this is, putting a huge physical strain on them. But there's also the fact that in understaffed healthcare systems with poor training specifically on UI management, this can exacerbate a lot of the challenges that we know are already faced by health and care workers. So I've talked a lot about the issue, but I also want to talk about the solutions and the innovative practices because there are some, and it's important to highlight these because many people are not aware that we do have options. Of course, there is person-centered continence assessments. We can also offer pelvic floor muscle training, bladder training, and time toileting and lifestyle interventions. There are also indwelling or intermittent catheters. So this is, of course, when it makes sense, when it's clinically indicated. So not necessarily for everyone, but there's also external urine collection devices for women, which can be used even for bedbound patients and when they're sleeping. There are digital tools such as the Urine Control app, which is free and allows for personalized management. There's also an opportunity for improved staff education and training, especially on female continence care. And lastly, as I've mentioned, sustainable approaches to reducing the use of absorbent hygiene product. So, with all this in mind, we want to put forward some recommendations and policy action. So again, I encourage you to take a look at our white paper where we discuss this in more detail. But we look to you to help us elevate the visibility of UI. This is why we have events like this. This is why we're so grateful for the support of MEP Entercitis and the ALLIAX Alliance. We call for, reducing the environmental burden of UI management, improving education of health and care professionals on UI management, and supporting them in nursing homes through patient-centered, innovative, and sustainable management solutions. We also call for a strategy on women's health with a focus on UI, and we would like minimum quality indicators in long-term care introduced so that we can strengthen equity and monitoring across EU member states. So just to sum all of this up, EU and national policymakers should elevate the visibility of UI by integrating it into aging, long-term care, and broader health strategies to improve its management and reduce its burden on nursing homes. So with that, I will end my presentation. Thank you again for all of you for attending today, and I look forward to the panel discussion.
Thank you. Thank you very much, Alexis, for this very insightful presentation that really very well outlines the work that we've done throughout the year with the Alliance. Now, I would like to go slightly off schedule because I see that one of our panelists, Panagiota Tixala, has been able to join us. So Panagiota is a registered nurse, as you probably can see from her outfit today. So she's joining us from work, and she's also a policy officer at the European Specialist Nurses Organization. And I know, Panagiota, that you have a very limited time with us, so thank you very much for making the time to be here. As we have heard from Alexis and her presentation, the paper highlights that current continence management practices contribute significantly to the production of healthcare waste. Can you describe a little bit what this looks like in practice and why this is an important concern, especially for the nursing sector?
Hello, I'm sorry that I cannot stay longer, but something came up and I had to work. So about the question, from a personal also experience in the European, at least nursing homes, the continence care relies heavily on the single-use products, absorbent hygiene products, pads, briefs, underpads, and I think this is almost maybe 10 or 15% from the total healthcare waste. And one resident in a nursing home maybe require 4 to 6 pads in 24 hours. And if you multiply that, let's say in a nursing home there are maybe 100 residents, this creates a significant daily waste volumes. And after, it's also the gloves, the liners, the wipes, the plastic bag underpants, that they also increase the waste. And I also have to say that I am a nurse for 24 years in different settings in 4 European countries. Until now, there was no focus on the specific topic. I have two bachelors. I finished my first master's. I'm finishing now my second master's. The specific topic was never, at least from what I know, included
Mm.
as educational topic for nurses. And the issue is, of course, ecological, but it's also ethical.
Yeah.
It's also for the human-centered care is really, really important. So I think that what you do is important. It's also important to include nurses on the specific topic. And yes, I will not take more time. I'm
No,
sorry.
thank you.
Because it's so interesting, I can talk for hours. I'm sorry.
No worries, Panagiotta. I think that's a great and important point. And you actually mentioned these that yourself. I mean, you started and you prompted these other questions that I would like to ask you, which is
Yeah.
nurses has really an important role in implementing change. We know these from practice. We have seen this multiple times. So, what support and what policy measures do you think that would help? Nurses and nursing professionals to lead this transition towards what is a more sustainable continence care, but also more person-centered continence care.
I believe that one of the activities, one of the focus that the European Specialist Nurses Organization has, and also with our very important event that we had in Brussels in November, it's to include nurses in the policy design. For the European Union, at least, we really need to harmonize the standards and the education of nurses, to support nurses, to learn about this topic and to be included, raising awareness and learning about sustainability, about how can we really change something. I find this important. We are the biggest part in every healthcare system, and sometimes we're not really included in the decision making, and we really need to invest in the education and the training of nurses. It is important because we need to have human-centered care, and the patient is a part of the healthcare system as the healthcare professional, as the stakeholders, as the managers. The patient is a part of the healthcare system, and we should see it like this. Thank you.
Perfect. Well, Panagiotta, I don't want to keep you longer because again, I see you're working. Would you like to share a final thought before we go on with the webinar and we'll let you go back to your work, like a call to action or something that you wish comes out after this webinar?
Yeah, I would like to hear more about all these activities. We would really like to be more involved as nurses and as ESNO. And I really hope to see more activities on that. Very well done. Thank you for having me. I'm sorry that I cannot stay more.
No
And
worries,
I wish
Panagiotta.
you a
We
nice
thank you
day.
very much for actually making the time out of your work day to connect and join us. Thank you. And as we mentioned, this webinar is going to be recorded, so you will be able to then
Okay,
follow up the rest of the discussion. Thanks again, and
excellent.
have a wonderful continuation of your day. And
You
with
too.
these, we
Thank you.
move back to the original schedule. So I am happy to welcome again Pascal Schortner. He is the managing director and the head of inpatient care of BPA. Is also member of ECHO, which is the European Confederation of Care Home Organizations. So, Pascal, you do oversee inpatient care. You have a lot of experience in the sector. How do the realities of urinary incontinence manifest in nursing homes, both for residents, but also for the staff that is involved in providing the daily care?
Thank you very much for the question and the introduction. At BPA, we represent 14,000 nursing homes and outpatient care institutions in Germany, employing more than 400,000 nursing staff. So there's a lot of experience in our member organizations. When we look at urinary incontinence in European nursing homes, we are not dealing with a niche phenomenon, but with a widespread, socially taboo and highly consequential aspect of long-term care. In Germany alone, we are dealing, or in Germany alone, up to 10 million people are affected by some form of incontinence. And in nursing homes, the numbers are even more striking with roughly up to 70% of residents that live with urinary incontinence. That means for the majority of residents, continence care is not a peripheral task, but it is part of daily life. From a resident's perspective, incontinence can be emotionally challenging. Many people hesitate to seek medical help due to embarrassment, even though effective treatments do exist. Factors such as cognitive impairments or environmental barriers in the home may limit early continence promoting measures. And still, personalized approaches, including toileting schedules, bladder training, pelvic floor exercises, and lifestyle adjustments, can greatly improve comfort and autonomy when adapted to individual abilities. At the same time, incontinence care has a profound impact on nursing staff and on the organization of daily work. Tasks such as cleaning residents, changing absorbent products, handling bedding, or supporting nighttime toileting take up a substantial part of the working day. And these are all physically demanding activities that can, as also was said in the previous presentation, contribute directly to musculoskeletal injuries. Another aspect to consider is how continence promotion and basic incontinence care must be balanced in everyday practice. Staff prioritize residents' comfort and safety, which often means responding quickly to immediate needs, such as changing pads or supporting toileting, which also means that continence promotion, when it comes to bladder training or structured assessments, which requires continuity and close coordination with residents, can sometimes take like a back foot or come second to these more urgent daily needs. These processes take time and rely on cooperation, documentation, collaboration across all care teams. And when routines are busy, these supportive measures may be more challenging to integrate, but many facilities are continuously working to strengthen this balance. Similarly, the structured and evidence-based approach outlined in our German expert standard on continence promotion provides also a framework for facilities. It highlights key elements such as systematic assessment, individualized goal setting, resident education, and the thoughtful selection of continence products and supportive interventions. Our nursing homes align their practice with the standard, using it as a guide to integrate continence care promotion into everyday routines and to support consistent, high-quality care across teams. When it comes to absorbent hygiene products themselves, I think it's important to know there's no one-size-fits-all solution. Product selection must be based on anatomy, severity, the retention capacity of the product, and secure fastening. And at the end of the day, it's also based on what is affordable, especially if the health insurance does not pay for the product that might be suited best when it comes to just looking at the criteria. Increasingly, there's also other solutions. We have, for example, digital systems for absorbent hygiene products, sensor-based products that detect saturation, show promising results. They can improve sleep quality, reduce unnecessary changes, and even lighten staff workload. And in pilot studies, many residents reported better rest and less leakage, and more than half of nursing professionals felt a noticeable relief. However, there's high costs,
Yeah.
IT integration issues, and also sometimes problems among acceptance among staff and residents also, which remain significant barriers. So it is therefore vital that there's more research into all kinds of modern, innovative product for incontinence care. To sum it up, incontinence care is an organizational, social, financial, and emotional challenge. For resident, it affects dignity, autonomy, and comfort. For staff, it shapes daily routines, physical health, and workload. And for nursing home providers, it sits at the intersection of quality standard, staffing realities, and economic constraints. Thank you.
Thank you, Pascal. And if I can just ask you a little bit of a follow-up question, because you have given a very good overview of what is the situation, what are also some of the solution. But what are some very practical changes, maybe if you can mention one or two, that you think would make the most difference in easing the burden on care staff, but also improving outcomes for the residents?
So we heard already from the speaker before that, of course, training is a very important thing. We, as I said, have an expert standard on this, but of course, it needs to be constantly taught and put into practice so that everybody can profit from this academic standard. And then, of course, we need sustainable and economic resource allocation. So quality of care is ensured and does not depend on the individual's financial circumstances. And second, we need innovative solutions. We need to test them, improve them, see if they work. And if they do work, we need to be able to use them in everyday practice. So it includes appropriate financing solutions and appropriate teaching, learning, so that we can profit from innovation and so that there is a better quality of care and more time for other tasks, because there's always enough tasks for staff in a nursing home.
Perfect. Thank you. Thank you very much, Pascal. I am now very pleased to pass the floor to Professor John Essaker. He is a medical doctor with a specialization in neurology. He's also a member of the International Continence Society. He's a member of many other groups and associations in continence health. I won't mention them all, otherwise it's probably going to take a quarter of this webinar. John, I think you will be sharing with us what are some of the most promising clinical and technological innovations to transform the management of urinary incontinence. And I know that you have a presentation, so I'll leave to you to share your screen and walk us through your presentation.
Thank you very much, Federica. Okay, let me share my screen. This is the beginning, as you can see. So, yeah, thanks for the opportunity. I am a member of the ICS, definitely, but I was the general secretary of the ICS for the last 3 years. And the ICS is the International Continence Society, existing from 1972 on. And we deal with continence on a global perspective. And we do that in a multidisciplinary way with all professional activities that are included and also with patients. So what we try to do is solve this very invalidating problem. And well, it will be a bit of a medical talk, of course, and it has some environmental and organizational aspects as well. But I will focus on the medical part. So perhaps you know, but every 4 years there is an edition of the update of the volume called Incontinence. It's a book. It's 3 books actually on incontinence that is organized by the International Continence Society as well. We have the 7th edition in 2023, and next year we start the 8th edition. And on chapter 14 is a chapter that deals with incontinence in the frail elderly. And that, of course, includes also the residents in nursing homes. And as a matter of fact, we know a lot, and we also don't know a lot yet. And the real challenge is how we can improve our knowledge and also to put that into clinical practice in order to improve the care that we have for these people. Now, for instance, if you look at the comorbid medications and conditions that are in the frail elderly, there's a lot of diseases that cause continence by itself, like diabetes, joint disease, chronic pulmonary disease, congestive heart failure, sleep apnea. I can continue, stroke, Parkinson's disease, dementia, depression. And all these diseases have some kind of a behavior or treatment or a side effect that can cause incontinence. And perhaps this one, the last part, is the most important one. That's the environmental factors, meaning that if you have trouble with keeping your urine or your bowel closed, then if you cannot go to the toilet in time or when there is no toilet, then you have a problem only because of that. And that doesn't mean that you're incontinent, but you are made incontinent because of the environmental issues that are there. And that's something that we have to realize. And Pascal was alluding to that also in his presentation. Now then, another thing, we have medications for a lot of things, and these also cause incontinence. For instance, if you are using lithium because of depression, that quite often also causes polyuria, meaning that you make a lot of urine and you have to go to the toilet, which is difficult to control. That also goes for other medications. I don't go into detail here, but there's so many already without being incontinent that makes you incontinent because of the disease that you have or because of the treatment that you get. Now, what do we know? And I think that there are more knowledgeable people at the table today, but this is research from the incontinence book. If you do some screening, this is from US, which states that 48% of people in nursing homes are incontinent, and there's no clear plan to treat that. They just accept it as a fact, do containment, diapers, pads, etc., and that's it. That's US. I don't really know whether it's very much different in Europe, Pascal, but I assume that the percentages are more or less similar. And that needs to be changed. Well, why is that? Why is there no clear plan? Well, there is perhaps a lot of knowledge, there's not enough knowledge of the staff. There are practices that restrict mobility. There is limited access to the toilet because there's not enough assistant, and that of course has to do with the personnel that we lack. Perhaps there's lack of privacy and attention to the dignity of the people, which is very important. And of course, it's far more easy to put on a diaper than to help someone to go to the toilet. So that's one of the reasons. And is this necessary? Well, perhaps not. This publication, 2018, from Asia, says, okay, if you look at the prevalence of incontinence, urinary, fecal double incontinence, that's quite a lot, more than 50%. And if you are not able to stand or lift your hip, that means that the chances that you will get a diaper on is very much higher. And if you look at the people that are in this situation, well, about 80% were diapers, but 12% of those would also ambulate independently, and 52% were able to stand for 30 seconds. So perhaps these last two categories don't need to be incontinent if there's enough help for them in order to avoid their problem. And that's something that we have to realize and work on. Okay, what can we do? Well, lifestyle measures, yes, that's a very popular word. We have to change our way of life in order to be more healthy. We don't smoke anymore. We don't drink alcohol. We don't drink coffee. And we are very well in keeping our shape. So yes, it has some attractive features. So it is non-invasive. It has no side effects, socially acceptable. However, is it possible to do this in older adults because it needs caregivers in order to take care of the people that are involved here. They have to adhere to a protocol, which perhaps is not very easy. And what do we know about the effectiveness? It's a popular word, but do we really know from research that this helps and to what extent? So something needs to be elucidated there. What we know from our ICI committee, so from the same book, Incontinence and Failed Elderly, well, we know that there are not that many studies that are involving older people. We don't have that much evidence that behavioral interventions are positive, that they are effective. So we cannot give any recommendation in frail people from a scientific point of view. So the professionals say, okay, we don't have the real science yet. There's not enough evidence to say yes or no to do this. Well, what works? This is interesting. We have a lot of indwelling catheters that are used very easily. Also today, not only in nursing homes, also at home, also in hospitals. And we also know that internal catheters have some problems with affecting infections. It is not good for the bladder. It's not good for the people. So what can we do? Well, there are external external collecting devices which are very promising because they work in a more friendly way to the patient. It is more comfortable. It will cause less urinary tract infection, and there is less waste because you don't need all these diapers. Okay, some systems exist already, and that will be improved in the future. Now, in order to come to solutions from a medical point of view, we have to realize that there are two kinds of incontinence. We have urgency incontinence or overactive bladder complaints, as we call it. That means that's a bladder problem. The bladder contracts if you don't want it at the moment. So that's one. The second one is stress incontinence. That means that you have urinary loss during exercise, sneezing and coughing. That's what we call stress incontinence. It is a closure problem. Your urinary sphincter doesn't work that well. And we also have solutions for that, innovative solutions that perhaps will also be available in the older population. Well, what do we know from medication? Well, that's quite disappointing because you have always side effects with medication. As I showed you, there's a lot of co-medication in these people, and all these drugs interact with other medication, makes it more limited for the population that we talk about. We have to check all the used medication in these people, which is a lot, and we have to be able to control that. Who should do that? The general practitioner, geriatrician, the doctor in the nursing home, things like that. Not easy and not well organized yet. Unfortunately, we don't have many drugs in the pipeline at the moment for this disease. And if you need to do something, go for the easy fix. Make it easy in order to have some effect there. Perhaps it works, not very promising so far. So is this a realistic option in this group of patients? Then we have stress incontinence. So we have a sphincter problem. Well, normally we do complicated surgeries on the OR, on the local anesthesia. No, we do it on a general anesthesia or regional anesthesia. But there are some treatments that we have available at the moment that are possible on the local anesthesia. And that makes it far more appealing for this group of patients. For instance, if you talk about stress incontinence and bulking agents, what you try to do is improve the quality of your sphincter. You can do that under local anesthesia with a cystoscope. You put some bulk at the bladder neck, and perhaps that works in this group of patients. Mini slings, yes, these are polypropylene slings that can also be applied under local anesthesia. So we don't need a very extensive operation anymore. The issue, of course, is are these effective enough and are these safe enough? Because we have quite some issues at the moment with polypropylene slings from another point of view. But this is within reach. We can do this, and if we train ourselves very well, we can also put that as an option for the older population in nursing homes. Then we have botulinum toxin for overactive bladder complaints. Under local anesthesia, very appealing. We do it in the older population. It also means that people come in to the office, get a treatment, and go back. Don't have to be on the ward of the hospital, can go back to the nursing home again. You can do it once yearly, which also makes it very appealing. And the difficulty here might be that there is inability to void after the treatment. That can be the issue, but it's possible. And then this will be also very promising for the future. We do treat neuromodulation, we do treat overactive bladder with neuromodulation. That means that we try to influence one way or the other the innervation system of the lower urinary tract. The classic type is sacral nerve modulation. That means that you have to put your patients on the belly in prone position. You have to do 2 surgeries, and that's not very much liked in older population, like 80-year-old women or men, because men have the same problem. But there are also more appealing and easier to do neuromodulation types, like the transcutaneous tibial nerve stimulation. You can do it percutaneously already, and even under local anesthesia, we have now an implant that can be used especially for this group of patients, because you just put them on the back for half an hour and that's it. So perhaps you were looking at the strange picture behind my face during my presentation, but that's because the ICS of 2026 will be organized in Maastricht, my hometown, and there all these aspects will be discussed and improved, hopefully again. Thanks for your attention, of course. If you have questions, I'm happy to try to answer them. Frederica.
Thank you, John. Thank you very much. And I actually would like to mention this to the audience, that if you do have any questions, you can either put them in the chat or in the Q&A box, and we will absolutely get to those questions in just a moment. I am also pleased to see that MEP Vytenis Andriukaitis has managed to join. MEP Andriukaitis, I hope you can hear us and see us.
Yes.
We can hear you and see you.
Can you hear me?
Yes, very well.
Okay.
Thank you so much for making the time. We appreciate that you have a very busy schedule. I'll just give you a brief introduction of you, although you need no introduction. MEP Andriukaitis is a medical doctor himself. He has been the European Commissioner for Health and Food Safety from 2014 to 2019. He is currently a member of the European Parliament, as well as a member of the MEP Interest Group on Continence Health. MEP Andriukaitis, thank you very, very much for being here. I think that what we are most interested to hear from you is how can urinary incontinence be better integrated into the EU policy framework on healthy aging, gender equality, and long-term care.
Thank you so much, dear colleagues, dear like-minded friends. I'm very happy that you invited me as a member of the interest group, but first of all, I know that how sensitive this topic is. And of course, let me begin by sincerely thanking EHMA and the ALLIAX Alliance for convening this important discussion, and crucially for putting this often overlooked issue firmly on the European EU policy agenda. It's really overlooked issue, for sure. We know very well. As a member of the interest group on continence health, I welcome the opportunity to shed light on a health challenge that remains largely invisible. And it is painful. Urinary incontinence in older women, particularly those living in nursing homes, in living, in social homes and in long-term care facilities across Europe. I know personally, as medical doctor, I had a lot of cases when I saw it with my eyes. This conversation truly comes at the right moment. Europe is rethinking how to deliver dignified, equitable, and sustainable long-term care. And this topic aligns perfectly with some of our most important European Union objectives: promoting healthy aging, advancing gender equality and equity, and making our health and social care systems more sustainable. Sustainability is a very excellent word. Now you can use such sustainability in every corner. But how can we, guarantee sustainability? It's a really challenging issue. Urinary incontinence affects millions of European women, especially those in long-term care. Yet it remains underdiagnosed, underreported, and too often dismissed as simply an inevitable part of aging. But its consequences are anything but inevitable. It undermines dignity, it limits autonomy, and it profoundly affects quality of life. For many women, it contributes to social isolation and depression, and also loss of confidence, and adding to the already significant mental health burden among older women. For care staff, inadequate continence management increases workloads, for sure, creates stress and raises occupational risks. It reflects structural gaps in training, in resource allocation, and in recognizing, continence care as one of the core components of quality long-term care, especially the long-term care facilities. Economically and environmentally, our current management practices generate enormous waste and cost for facilities, for families, and for our health systems. So that the task ahead is not only to treat symptoms, but to embed continence care into European health and care framework. Urinary incontinence is not only a medical condition. It is a gender public health issue. Women are disproportionately affected due to biological and life course factors such as childbirth, menopause, and longevity. Yet their needs remain underrepresented in research, underfunded in innovation, and insufficiently integrated in care models. If we want to correct this imbalance, we must ensure that continence health is fully integrated into EU policies on healthy aging, women's health. Till now we do not have women's health strategy or reproductive health strategy, and long-term care. We have strong EU-level instruments that, if used strategically and if they will use in coherent manner, can transform continence care. First, please keep in mind that European Commission proposed a European care strategy. The European care strategy offers an opportunity to embed continence management into the quality, workforce, and person-centered dimensions of long-term care. Second, programs such as EU for Health and Horizon Europe can support innovation from sustainable product design to digital monitoring tools. Just we heard previous speaker. To research that improves data collection and care pathways. Third, the European health data space can finally generate high-level and high-quality comparable data on prevalence, on outcomes, and on standards of continence care across member states. Data we urgently need to design better practices and better policies. And fourth one, we all know Green Deals, and we know all the Circular Economy Action Plan. But directly, they are relevant, given the massive waste footprint associated with single-use continence products. And it's a very big challenge in all long-term care facilities, of course, also in some public spaces. The time has come to connect these instruments under a coherent European Union framework on continence health, treating it as an integral part of healthy aging, women's health, and sustainability. At the heart of this issue lies a simple principle, but very one most important, related to European Union values: dignity. Even every older woman in Europe deserves respectful, person-centered continence care, regardless of where she lives or what resources her care facility has. But dignity goes hand in hand with sustainability and innovation. And of course, we can encourage eco-design reusable, and less waste-intensive products to reduce environmental impact. And it is especially important to our industries, to our, those who are producing it. Second, we can support better training for care staff, improving care quality, reducing complication, and strengthening staff well-being. Of course, we know that in long-term care facilities, healthcare workers are doing an excellent job, but it is very dangerous, very difficult one. And of course, we can respect their staff well-being and leverage digital tools and smart data to personalize continence care and optimize the use of scarce resources. Because you know very well, the resource also always under big financial pressure. The EU can and should act as a catalyst by supporting cross-border collaboration, scaling good practices, and promoting innovations, including those emerging from initiatives such as ALLIAX is doing. Let us ensure that urinary incontinence is no longer treated as a private or taboo issue, but as a legitimate part of the European Union public health and social care agenda. As policymakers, we must work together to break the silence surrounding continence health, integrate continence management into EU and national healthy aging strategies, and support evidence-based, person-centered, and environmentally sustainable solutions. And we need to keep in mind that European care strategy should be, harmonized with national care strategy plans, which should include those all components into their remits. This is not a niche issue. It's about fairness, dignity, sustainability in our care system. It's about also about about human rights. If we act together, policymakers, clinicians, industry, researchers, and civil society, we can ensure that continence care becomes dignified for patients, supportive for carers, and sustainable for our societies and for our communities. I think this topic should be discussed in very coherent manner, in very cooperative manner, avoiding silo mentality, especially keeping in mind that different programs are not always united, as we see sometimes in our real life. Thank you very much.
Well, thank you so much, MEP Andriukaitis, for your time, for making the time out of your busy schedule. It has been really a pleasure to have you here. I know you need to move to other appointment in your agenda, but it really made a lot of impact to hear your words and to hear your commitment into making urinary incontinence again about dignity and human rights, and humanize these condition and put people at the center.
Yes, please count on us. Let's activate our interest group, and let's see how because we now are in very good moment to press commission to present women health. But urinary incontinence would be included. It's timely. Let's be very active. Let's continue our efforts to achieve those results.
Absolutely. Thank you very much. We will absolutely do that. We will be in touch with you, and we will make sure that we continue to follow up on this important topic.
Thanks a lot. Please present to me your results, your outcomes. It would be good to be in touch and of course to follow you, because we need to have your feedbacks. Because speaking about women's health, or of course our reproductive health and women's health together, we need to keep in mind that urinary incontinence is very big topic. It's I spent a lot of years in practice, more than 20 years. I know what this means.
Yeah. Perfect. Well, thank you again, MEP Andriukaitis. It has been a great pleasure to have you here. We will
I'm
certainly
sorry, I would like to go to my next meeting.
Of course.
And of course, I wish you good conversation. Please
Thank you.
don't hesitate to touch me.
Thank you. Thank you very much. We wish you good continuation of your day. As we thank again MEP Andriukaitis, I would like to move to our next speaker, who is Elena Weber. Elena, she is the board member of the European Aging Network. Elena, you have heard what MEP Andriukaitis just mentioned. I am sure it made an impact on you. And the question that I do have for you is in a sense is very similar. But first of all, what is your reaction to what you just heard? But also because you do work on aging and ensuring dignity of life and quality of care for the aging population. What are your thoughts and what are your reaction on how the EU can really mainstream urinary incontinence in the framework of aging, long-term care, and environmental strategies?
Thanks again for the invitation. It is a pleasure to be here today. And for sure, I agree, but not only with the MP spoke just some minutes before, but with a lot of the information we received during the webinar today. And if I can have some thoughts for the future and impacting EU and aging, long-term care and environmental strategies, I would like to focus on some small activities EU, but also all of us, we can support for upgrade or update also to today activities and the services, the life of person with the EUI. First of all, we can accept and go forward aging or supporting aging and above all well-being in aging with my first word, we can say a small action, that is prevention. This means that we must spread the voice inside our communities so to be heard. Sometimes, but probably a lot of times, it's a matter that we don't know where the services are. So we need to spread the voice and inform people, because everyone was speaking about this. It's a matter of taboos, and no one would like to speak about this. Some years ago, a person asked me about this, such kind of information in our territory, in our local community, and she never pronounced the term or the word in Italian about the UI. That's not possible. We must, as we say, we have something on our teeth. It's the same matter. We must pronounce the right word and ask for support. And if you are informed, you know where you can go and receive support. And also older persons living at home, because we are not speaking only about long-term care services, they can receive prevention, but also support if prevention is not anymore in the right level. Second point is definitely connected to long-term care services, because in almost all our structured premises, we are providing rehabilitation activities, and normally they are dedicated if there are something special or specific to be addressed, but they are also collective activities. And during collective activities, I think that a part of the rehabilitation time or schedule must be dedicated to UI rehabilitation, because this could be definitely general and shared. And it's another way not only to fight UI, but also to fight taboos in this field. And it's very, very important. And it's not an added cost. It's part of the activities, so we don't need to spend more money or more time. And also, what I would like sometimes to organize, but then it's never the right time, is to organize some public session or public speaking about the fact, something not so good as you are organizing, but good for the local communities. And this is bringing also to the third point that are connected to environmental strategies, because my hashtag here is sustainability. Sustainability in different sectors, in different lines that can be respecting the environment and so supporting SDG number 13, for example, but also trying to reduce cost and supporting indirectly SDG number 8, decent work and economic growth, as number 12, for example, responsible consumption and production. And above all, fighting loneliness and isolation, because I think that UI is always bringing you to, yes, not a bad condition of living, we can say. And there were studies in the last years before COVID that were demonstrating that there is a chance to have reduction of cost if you provide rehabilitation activities and support the person living inside LTC structures and premises in the field of UI. These are very important because we are normally thinking about the pads. It's not only a matter of pads, it's a matter of being able to fight, or yes, to fight UI before, so to be able to not become a person with UI sometimes. And also thinking, for my last hashtag is future, because there is always a future for working in this field, as MP was telling us, and in the same time to spread the voice. I think that this probably is the most important, not because the other are not, but because in this way we can think that there is a better day tomorrow, and we cannot leave it for only today discussion. Yes.
Well, thank you so much, Elena. That was really an important statement. I would also like to see, because we are approaching the end of our webinar, I would like to see if there are any question from the audience to our panelist. And of course, if you do, you can either raise your hand and I'm happy to allowing you to ask your question live, or otherwise you can put it in the chat, where I've seen that there have been quite a lively discussion. I particularly see Lynn, who was also mentioning, I think she did when it was MEP Andriukaitis speaking, to not forget the family and the informal caregivers, as of course one of the prime reason that people end up in care homes is the inability to cope by family, and the burden falls mainly to women as informal carers. That is the comment that Lynn just made in the chat. I just read it out loud for the speakers. So I don't currently see any question or hands up. So I'd like to pose to the speaker one of the question as we wait for others from the audience. Which is, I mean, of course, we have heard from Elena the concept of urinary incontinence as a taboo. The same was mentioned by MEP Andriukaitis. So maybe to you, Pascal, and then John, and then Alexis, what do you think could we need to make urinary incontinence a priority in the EU, and not put it on the side just as a taboo? Is it a matter of connecting with communities, being champions and speaking more openly about it. I'm very interested in your reflection. Pascal, maybe we start with you.
I think it was very well said before. We need awareness, and I think by talking openly about it, it becomes clear that it's not something that only the individual is faced with. Because of course, if as you know, in adult, all of a sudden you are faced with incontinence and all of that follows with it, it can be very intimidating. It can come with shame. It can come with all kinds of challenges that may lead to not seeking help, that may lead to isolation. So I think by talking openly about it in such formats as this, there were also other activities posted in the chat. And also in our own family networks and so on, it is a big step towards more awareness, which can lead to more resources, knowledge, studies, etc. And I think that's a very good first step.
Thank you, Pascal. Maybe John, I'm going to you next.
Well, I think it's improving. Like our MP said, that it's the time to have focus on these kind of problems. That, you know, with all respect, we many times and many years we focused on oncology mainly being the most challenging health problem in whatever country. What we see now is that quality of life is very much important in all kinds of activities, and that means that we can focus on that and also take that seriously. And I think that if we look at the way communication is done at the moment everywhere in the world, we have influencers, etc. Well, let's mobilize these people that are popular, that are able to attract many people for whatever topic. We can use those people to increase the awareness of this problem, and also to get it out of the taboo. And I think it's improving. Of course, it can be done far more better than it's done now. But I'm not that negative and not that pessimistic.
Perfect. Thank you, John. And Alexis, to you, a little bit of a slightly different question, which then I will also pass to Elena. We know from for the work that we do at EMA how important it is to co-create solutions. We heard Panagiota at the very beginning to make a very open ask about let's involve nurses in developing solution. The questions that I have to you is how can we ensure that we also hear the voice of older women and healthcare professionals in shaping policies and practice? And then, Elena, I'm coming to you with the same question, so you can start preparing your answer. Alexis.
Thanks for the question, Federica, and it's a very important one. Well, as Director of Policy and Research, of course, I'm going to say more research where we include patients and healthcare workers in this research in terms of their needs, their concerns, and what can improve their quality of life, both the mental impact, but also physically. I think for me, that would be absolutely the first thing, and keeping them engaged at all stages, as we're working with policymakers, making sure that they have a seat at the table, that their voices are heard. It shouldn't just be someone in Brussels speaking on their behalf. We actually need the voices of the healthcare professionals, like we had with Paniota, actually being present and being able to share themselves. Thanks.
Thank you, Alexis. Elena, I'm coming to you with the same question.
I have again 2 lines as Alexis proposed. The first line is definitely at local level, because I think that this is an added value of European Union. We can work at the local level and then at the European Union level. And at the local level is trying to find a way, but I will speak a little bit later in the second line, to support activities and to share information, good practice, and above all, information. That's important. And the second level is, or it's a double line that is working together with the Age Platform Europe, that is the voice of older persons in Europe, and so also with older women in Europe. And there is specifically a member of Age Platform that is Older of Women Network. And in the same time, thinking not only on medical or health condition, but in a different field or a slightly different field, about a possibility to have an Erasmus Plus project to raise awareness and to develop strategies to inform the population. Not only, I repeat, on medical and health issues that are definitely important. Thanks.
Perfect. Well, thank you, Elena. That's a very concrete proposal, and you actually give me a prompt to go through our speaker for a very last, let's say, call to action or things that stayed with you after these webinar. I'd love for Alexis, Pascal, John, and Elena to share in really 30 seconds something that stick with you and something that it is definitely a call to action, either for you in your practice or for the audience that is listening to us. Let me start with how I see you in the screen. Maybe I go with Alexis first.
Thanks, Federica. Well, it's hard to choose just one because I think we covered a lot of ground today, and I'm so grateful for the panelists for being here and sharing their expertise. For me, it was what MEP Andrikaitis said about now is the time. It's all about timing. We know this when working with policymakers, that raising awareness, getting these messages raised and these policy recommendations put forward at the right time with the right people is the most important. So I say now let's act, let's take his advice and move forward quickly.
Thank you, Alexis. Pascal, I'm moving next to you.
Thank you. I think for me, very encouraging is also all the innovation in the field, all different kinds of treatments, exercises, and also new solutions to manage incontinence care. I think we need to focus on enabling the use of these technologies and innovations and to make them widely available for everybody that deals with incontinence care. And I think if we manage to do that, then that's a great progress for the people that are afflicted by it, but also for the people who try to support everybody else.
Thank you, Pascal. Let's move on to John.
Yeah, I agree with what Alexis and Pascal were saying, and I think that what we should divert our activities a bit more. So there is the momentum now to act. I think. I also think that what we did so far classically as research is that we were looking at the perfect patient population in order to test things, and I think we should move that to, let's say, okay, we do this intervention in this group of patients, and that's the older population in nursing homes or not in nursing homes, but with comorbidities, etc. So the ones that are excluded always from trials, and we should focus on that and say, okay, what's the appropriate treatment in these group of patients? That would be one. The second is, and that's a bit of a criticism to the EU, the new medical device regulation doesn't make this very easy. We should change that in order to test simple things in a more simple way than all these complicated rules that we have at the moment. Okay, that's a bit challenging.
Well,
thank you.
Thank you, John. And Elena, your key takeaway.
My last final thought is we can share the white paper, ALLIAX, you prepared or you help us to prepare inside the European Aging Network members, so that at least a group of long-term care premises are aware or which are the results and how they can promote and support the activities in the field of prevention and rehabilitation above all. Thanks.
Well, thank you, Elena. I think that these summarize very well today's webinar. Indeed, we do have a paper. You can find it on our website, emmaehma.org. We will be also sharing the recording of this webinar that will be available as well on our website. I would like to sincerely thank our speakers for being here and making the time to speak with us, and our participants. I wish you all a wonderful day, and thank you very much for having attended.